It's time for this week's Ask the Expert slot. I'm joined in studio by Arthur Cummings, consultant ophthalmologist at the Wellington Eye Clinic in Dublin, who's going to answer all our questions about laser eye surgery. Arthur, good morning.
Good morning, Pat.
Now, give us an overview of the history of this. Who invented it and when did it start?
It's interesting where it started. It started with the IT industry that was using excimer lasers to etch chips. And an ophthalmologist saw this and said, I wonder if this couldn't work to reshape the cornea. And so that's where the first thoughts came from. And in fact, the very first lasers that were built in Cork by the Summit Corporation. And so it started off early on the surface.
This is doing the eye from outside the eye.
That's exactly right. It was called PRK. We still do PRK today for some patients. And it started with PRK, and PRK took quite a while to recover and was quite sore.
Because effectively you had shaved the eye with the laser, thus impacting on the surface of the eye.
That's exactly right. And the eye has more nerves than any other part of the body, and they sit just beneath the skin of the eye, the epithelium. And so the procedure removed the epithelium, exposed these nerves, and it was really sore. And then someone thought, well, wouldn't it make sense to maybe create a little cap or a flap and do the laser under this? So this way you keep the surface intact, do the laser and put the flap back in place. And that was first done 23 years ago now. And that's worked fantastically well. In fact, so much so that today that would still be the primary surgical method of correcting refractive errors.
Now, what you're doing is the cornea or the lens of the eye, if you can't focus properly, it means that it's misshapen in some way. I mean, when you add glasses or contact lenses, what you're really doing is changing the optics of your body.
Exactly. So there are two lenses. The first lens, and the most powerful one, is the cornea, and that's right in front. That's the window to your eye, and that doesn't really move. That's a static lens. And then inside your eye, you have another lens, and that's the lens that starts malfunctioning in your mid-40s when you find you can't read anymore. And that's the same lens that, when it becomes dysfunctional, becomes a cataract. So there are two different lenses in the body, and these two procedures, the one in the cornea by means of LASIK or PRK, and the one inside the eye by means of cataract or lens surgery, are the two most common procedures on Earth now. And in fact, last year there was something like 20 million cataract operations and 4 million laser operations worldwide.
Now, the business of inserting a little lens, I presume it's made of some kind of plastic to address the cataract problem. I mean, that's been going on for quite a while, and now it's being offered to people, or a similar operation to people who just want to read without glasses.
That's exactly right. So it started off in 1951, shortly after the Second World War. A gentleman noticed that certain patients with certain injuries, pilots, and they had parts of the cockpit glass in their eye, just managed, or it didn't make much of a reaction. So he thought, this is interesting. There's certain materials that can be inside the eye and not cause a reaction. And that's when he had this idea about implanting lenses. Although lenses only really became mainstream maybe towards the end of the 70s, beginning of the 80s. And initially they were made of a similar glass material, PMMA. They then reverted to silicone. And in the last 15 years, the material of choice has been acrylic. So now they're made of acrylic. They're tiny structures that are put in through very small incisions. So they fold through the incision and unfold inside the eye. And you spoke about not needing glasses for reading. So you can implant lenses today that are multifocal, which means each eye can see far and each eye can see near.
The reason the eye doesn't reject these, I mean, if you put in something plastic close to the heart, you may have to take anti-rejection drugs. Why does the eye not need these kind of things?
That's a super question. The main reason is because both the cornea as well as the structures around the lens are totally avascular, so there are no blood vessels. So there's nothing that can bring the antibodies or that are going to respond.
Who is a suitable patient for treatment with laser eye surgery, or with this little lens drop-in technique?
All right, first of all, it needs to be someone who wants to get rid of their glasses or contact lenses. This isn't a procedure you do because someone else wants you to do it. It's because you want to do it yourself. And then secondly, for the laser procedure, you need to be healthy. Your eyes need to be healthy. And then you need to have a suitably thick cornea, a certain shape of cornea. And if you then understand the risks and benefit ratios, then it becomes a very attractive option.
When you say you have to have a certain thickness of cornea, I mean, are there people with very thin corneas that won't take the shaving, if you like?
Yes, absolutely. And that's something that you wouldn't know until you've had a thorough examination and the tests are done that tell you how thick the cornea is.
Now, how much of this is high tech in the sense that it's not an optician, if you went to the local Specsavers or whatever, looking into your eye? This is all done by machines which are measuring and seeing inside the eye.
Yeah, this has all become very, very high tech. And in fact, an evaluation at the clinic takes about 2 hours from start to finish. So every part of the eye is measured in so many ways and visualized in so many ways that you can, de-risk. You want the procedure to have 100% success. And because it's a human operation and there's healing involved, that's not the case. It's not always 100%, but it's pretty close to that. But to push those limits, to try and make it a perfect procedure every time, all depends on the workup. So it's really important to have a good diagnostic workup.
When I had it done, I think it must be 15 years ago, I mean, there was a machine that measured the eye and the curvature of the eye, and then a computer calculated what needed to be done and instructed the laser machine actually what to do.
Squeamish about it. I show them a little video that's on our website about how it actually works. And the way the laser makes the flap is it has 2 laser beams that meet at a point at the distance you determined, maybe 120 microns. And where these laser beams meet, they create a small micro explosion with a small little resultant bubble, an air bubble. So you then have a couple of million of air bubbles in the cornea, in a line, and this causes a separation. And in fact, if for whatever reason you decided not to continue the procedure, you'd stop, and half an hour later the air bubbles are gone. And it's like nothing ever happened.
Sealed up again.
Exactly.
My memory of it was that, and they kind of mark crosshairs on your eye with you're anaesthetised. Your eye is anaesthetised. Yes. You can still, everything that's going on. And then they brought in this little saw at the time, and it was like taking the top off an egg, but leaving a little hinge of shell. They just popped the top back. Then they lasered me, and I think 30 seconds later, the flap is put back. The crosshairs indicate that it's put back exactly as it was. And then you go off and you have a cup of tea or whatever, and then you come back and they check it out. And the next morning you come back again and they say, yeah, it's fine, off you go.
That's how it works for most people. That's how it works 99% of the time. On the odd occasion, things don't go that smoothly, but exactly, you're right. Today it's become even more controlled. I mean, for argument's sake, the eye tracker that follows your procedure during the procedure, or your eye during the procedure, now has 6 dimensions. It follows X and Y, it follows height, Z, it follows tilt, it follows roll, and it follows rotation of the eye. So it's so sophisticated now that once you've engaged everything properly and the patient's properly aligned, you basically are assured that what you're trying to deliver on the cornea is going to happen.
Okay. Now, when you're doing the other operation, which is the one inserting the little lens that may fold out and it can be have various different qualities attached to it, people say, well, my eyes are great, I'm 45 or whatever. At what point do you say, okay, the deterioration is now complete? You are suitable for this treatment. In the same way with children, you don't do certain procedures on children, whether it's dentistry or anything else, until they're fully grown. If the eyes are deteriorating, at what point do you say, okay, you're 60, time to do it?
It's a very good question again. Your basic prescription doesn't change much. What does change in your mid-40s is the ability to focus up close. And the reason's quite fascinating, is the lens, even though it's inside your eye, has the same origins as skin, nails and hair, so it never stops growing. So as the lens continues to grow, so it becomes less functional or more dysfunctional. So if you have perfect eyesight your entire life long, and you start wearing reading glasses for the first time in your mid-40s, what you'll find is every 18 months, you need a slightly stronger pair of reading glasses. So you know this when you do the procedure, is when you implant the new lens, it's going to be a fixed lens. Currently we aren't implanting lenses that can move. So most lenses are fixed, and they'll give you a fixed focus. And if you're going to put a lens in that's multifocal, then you would now put a lens in that's going to give you a lifetime of whatever multifocal power you chose.
But it could mean that you'd have to do it again.
No. No, not with a lens implant. A lens implant, you've taken away the only moving part is the lens. The cornea is typically stable throughout life, even after laser surgery. The length of the eye is typically stable. The part that changes is the lens inside the eye. So once you've replaced it, then you have a pretty stable situation.
Now, talk to me about possible side effects. People would be worried about infection, opening the eye up like that, whether it's for either of the two procedures you talk about, and also the idea of dry eye, where you have no tears to keep your eye lubricated.
Exactly. I think that's the number one problem that we would see is dry eye, although it's become an awful lot less. With LASIK, like you described before, where a blade was used, the nerves were cut. Now the way LASIK flaps are made with the air bubbles, the nerves aren't hurt in such a way. So they find a channel very quickly again to grow back into the flap. So we've seen in the last few years, and it's also in our literature, that the difference in dry eye between a surface procedure and LASIK is now minimal. It still would be our number one complication that we see. As far as infection goes, touch wood, we've been very fortunate we've never had one. And if you look at the subject of infection, our literature says there's a 1 in 10,000 chance of an infection, and most LASIK procedures are done in clinic environments. So if you were to get an infection, it would be with a more benign bug and one that's going to respond more readily. Another thing about LASIK, which is quite unique, is because you're so comfortable so quickly, and all bugs have what are called incubation periods. So if you pick up an infection today, you won't have it tomorrow when we see you. Tomorrow you'll look fine. But 5 days later, it would manifest. And within a day or two, you're seeing well and you're comfortable. If you suddenly found 5 days later you weren't seeing well, you'd know something's wrong and you'd report it pretty quickly.
Do you prescribe antiseptic drops routinely for people who've had this kind of surgery?
Yes, we do. Absolutely. I think
as a prophylactic.
Yeah, that would be more so as a post-op, but as a prophylactic. Yeah.
Yeah. Now, my wife has. I can't know how to pronounce this. Keratoconus.
Yes, keratoconus.
Right? Is there a laser treatment for that from Colin in Delgany?
There is a laser treatment for that, but it's very, very specialized. It's highly specialized. So the problem with keratoconus, for those who don't know, it's a condition that affects 1 in 2,000 to 1 in 1,000 people perhaps, and it's a condition where the cornea is slightly thin, and then mostly due to an aggravating factor like hay fever and rubbing of the eyes, you now get this condition where the cornea starts steepening. It starts becoming thinner and thinner and starts steepening. And just as recent as 7 years ago, all we could offer was the use of the hard contact lenses, and if at some point they weren't working anymore, you'd go for a corneal transplant. But 7 years ago, we introduced a procedure to Ireland called corneal cross-linking, and corneal cross-linking stabilizes the cornea again. It strengthens the fibers and stabilizes the cornea. Now, if you do have very sophisticated lasers, like a topography-guided laser, you have the option of, at the time of surgery, to first improve the shape of the cornea and then directly thereafter to cross-link and stabilize the new improved shape. So it's something we do, but it's maybe only 25% of our keratoconic patients are treated that way.
My daughter had lenses implanted at 5 weeks of age. 5 weeks. Amazing stuff being done by the eye team in Crumlin. Can't praise them highly enough. That's from Sean from Crusheen. You have sitting in front of you the world's best eye surgeon and a gentleman as well. That's from Sam. That's a compliment to you, Arthur. Hi, can you please ask your guest, does he ever envisage a cure for the vision of someone with a lazy eye?
That's a super question. We know that lazy eye occurs mostly during your first 7 years of development. And if you catch this in time, you can certainly turn that around. And when I trained, it was believed that once you're 7 or sometimes even 11 years of age, the opportunity is gone. But there's a treatment that started in Israel called Revital Vision, or it was called Neurovision then. It's now called Revital Vision. It's been FDA approved, which helps the adult brain relearn how to see with an eye. So a lazy eye is nothing other than an eye that the brain has chosen to ignore. And so it's just brain training on how to get it back again. We've used it maybe 5 or 6 times for someone who wants to get into the Guards or wants to become a pilot, and it can gain us maybe 2 or 3 lines. So if you understand what you need from it, if you understand its limitations, and you want it for a specific goal, you'll do it.
But it is an exercise regime, is it?
It's about half an hour a day that you do for, I think, 40 sessions. And once it's relearned to be used, you'll use it.
Is the eye procedure available to the over 60s?
Absolutely.
No age limit on surgery in this regard?
No, not at all. As far as laser goes, is once you start approaching your 70s perhaps, you may start finding that there's early cataract. And if there's early cataract, you wouldn't want to punish the cornea for the crimes of the lens. So you'd rather treat the lens then. But
my husband had laser eye treatment successfully some years ago. He always said the most painful part was paying the bill. Now, tell me about the cost of these things. Is it a standard cost no matter what the procedure for each one of the two procedures, or does it vary depending on complexity?
The costs do vary depending on exactly what you're going to do. We don't have a price. We have a price for laser eye surgery, which is LASIK, and we have a price for laser eye surgery, which is on the surface. But whether we use any one of the new sophisticated ablation profiles, or we choose to make one eye better for distance, one eye better for reading, those aren't additional costs. And as far as lens surgery goes, the major cost is determined by the lens that you're going to use. I mean, a standard lens costs something like €130, but if you're using a sophisticated lens, you might pay €600.
All right, so the cost of the lens added to the cost of the procedure will determine your ultimate bill. But typically, if someone goes in with bog standard short-sightedness, for example, they want to sort it out for driving with LASIK, 2 eyes, what kind of bill would they pay? I won't hold you to this, but
it's very close to €2,000 per eye, of which you can claim back 20% from tax, and some of the insurers also give a 50% rebate. People may see prices in the newspaper or on television for less, but once they've been for their evaluations, they typically come out with the same bill. So that
what about I think in the United States, they may well be doing this kind of surgery in the shop window of a pharmacy or something like that. What do you think of that kind of offer? Because people might be tempted on holidays just to go in and do it.
Well, that's happened here too. I think the key thing is when you go for a procedure like this is to realize you have one pair of eyes, that you need to do the best you can for them. You need to make sure, number one, that you're a good candidate. And being a good candidate means you want a bit of a history that you get from your local optician. Your local optometrist will give us an idea of how stable you've been, what your ophthalmic history has been. So no, I don't think so. I think the few other medical aspects that you would simply do that and walk into a place and just have it done in a shopping centre. But it is an issue. It's happening. It's occurring more and more. And people are caught by the lure of the price. But once they're in and the procedure's upgraded to wavefront or having the laser make the flap, then when they look again, they're paying the same as they would in one of the consultant-led clinics.
Another endorsement, listening with interest to Mr. Cummins. He performed laser surgery on my eyes 15 years ago, and it was a life-changing procedure. I would highly recommend it. That's from Martina in Gorey. Now, the kind of people who will get the most dramatic benefit from this, I mean, okay, throwing away the pair of spectacles is one thing. But if you're someone who, when you open your eyes in the morning and you can't even read the alarm clock beside you, for people like that, it's very dramatic. Is there a range within which you say, yes, we'll get great results from minus whatever it might be to whatever it might be? And are there people who just, you have to say, you're too far gone, you're too short-sighted, too milk bottle lens is about the only thing that'll help you to see.
Exactly. It depends on the amount that you're treating, and it depends on the laser you're using. So for some lasers, once you're over -6, you shouldn't be doing LASIK. Our laser has a very wide range up to -12, although we very seldomly go over -10. The moment you start going so high, you start thinking about doing a lens implant instead, because there are no limits with the lens implant. With a lens implant, you can treat -30. So there are no limits. What's interesting is I've been very surprised over the years. I'm doing LASIK this year for 20 years, and I'm quite surprised at how often you would expect a person who would be really absolutely over the moon and elated. Most people are, but the one who really stands out as being over the moon would be someone who is really, really short-sighted. And it's not. Most people who are absolutely blown away are those who are only slightly short-sighted. So the person who's very
the person who's trying to do without the glasses
yes,
a lot
exactly.
of the time.
So the person who really can't see without them can't hate their glasses. They might despise them slightly, but they can't hate them because they're so dependent on them.
Yeah.
But the person who's continuously annoyed by them because I forgot to bring them to the match today, or it's raining now and it's raining my golf game, they absolutely love the freedom of being able to see well.
I mean, that business of sport, particularly, I mean, in Ireland, in the rain, playing a game of tennis or football. And I'm always surprised at the number of rugby players who find themselves scrambling around looking for a lens that's popped. You'd imagine that LASIK for them would be almost a career choice.
I agree with you, but you're absolutely right. I guess part of it is the fear again, the unknown factor and the fear. But there's some very well-known rugby players who've had laser done and very successfully too.
This one, have there been any advances in the technology for people with weakness of the optic nerve, even though the eyeball itself is fine and healthy? That's from Aidan in Mayo.
Aidan, it depends on what the cause is of the weakness of the optic nerve, but there's some very interesting work recently on gene therapy, where people have injected a gene into the eye for someone with an 11-year-old with Leber's congenital amaurosis, the condition's called, and where some vision was regained. So there's fabulous work being done right here in Ireland, in Dublin.
This one here from Pete. Can laser repair retina damage due to toxoplasmosis infection?
Pat, when you have an acute infection, the only treatment would be antibiotics. And then once it's an old lesion, then laser can only form a barrier to preventing retinal detachment. But as such, to treat the toxoplasmosis lesion, no.
No, it can't do anything for that.
No.
Another one. I'm in my late 40s, no problem reading, but problem with sight more than 50 yards away, and I'm a mad golfer.
Right, so that's a very interesting situation that you have to think about, because the moment you correct the vision for distance on both eyes, seeing as he's a mad golfer, he'd want his vision to be as good as possible, he's going to find that he now needs glasses for reading. So he'd be swapping one set of glasses for another unless he did something called monovision. And monovision is where you have the one eye better for distance, the one eye better for near. So potentially, if he had one eye treated only, he may find he gains distance vision without losing his near. So it would be worth trying it with a contact lens first.
I got half and half. I got completely lasered for distance on my left eye. I have to check. And then on my right eye, I got it half done so I could still read. And it takes a day or two, but after that, the brain says, fine. Thank you.
You've got an amazing brain. For most people, it takes about 6 weeks or so to have an idea of whether this will work or not. We normally do a trial before the time with contact lenses, or we do an exam in the office, in the clinic, that gives us a very good idea of how you're going to get on with that. But it takes about 6 weeks to get used to it, and then it gets better for the next 2 years. And you said something earlier where you said, I've almost got to check which eye is doing what.
Yeah.
And that's exactly right. You see with your brain, and your brain simply refers to the camera that it needs to use.
There is one thing I have discovered, though, in your half and half, is that when the light is low, the 18th on a golf course, dusk has arrived, and you can see the lights in the clubhouse are burning bright, so you know it's far darker than you think. And then you can't see very well. And equally in a restaurant, by candlelight, trying to read those menus can be a difficulty.
Absolutely, you're 100% right. Monovision is an absolute art, and it depends on how your brain manages it. And if we could give our brain direct instructions, we could resolve this. But you can't give your subconscious brain direct instructions.
By closing one eye, by the way, closing the distance eye, I can read the menu.
Absolutely right.
And I look a bit odd when I'm doing it.
And on the golf course, if you close the reading eye, you'd find the vision improves again.
Yeah.
So at the end of a golf round, you're quite tired, and your brain's just saying, I'm not going to spend my energy now suppressing the reading eye, so it starts focusing. So it's all about brain training. We've got a video on our website that shows people who have monovision how to train the brain to make it work better.
What's the address of the website?
It's wellingtoneyeclinic.com. And then there's a YouTube link, and it's on the YouTube link.
Is it possible to get rid of floaters in the eye, asks Jerry?
There is, Jerry. There are a couple of ways of doing it by means of surgery, but that's hardly ever recommended. The surgery itself is not without risk, and mostly once you've been assured that your eyes are healthy and your retina is healthy, and your subconscious brain again hears exactly what the floater is. It's a piece of material floating inside the eye. It tends to switch it off, and also we know over time the floaters are going to move away out of the line of sight. And the moment your brain hears that, it tends to do a very good job of switching the floaters off. But you do find patients where they just won't go away, and then you can do a procedure called a vitrectomy, where the jelly in the back of the eye is removed, it's replaced by water, and then the floaters are gone.
It sounds like a serious thing to be doing, though.
Yeah, it's more serious, but it's, the people who do it are very competent, but they'd be the first to tell you, don't do it until
it's really intrusive.
Really bothering you, exactly.
Yeah. I had LASIK in 2005. In 2008, I developed CSC in one of the eyes. Do you think it's related? My LASIK was and has been and is an incredible life-changing success. Otherwise, that's from Derek. What's CSC?
Derek, sorry to hear that. CSC is a condition called central serous chororetinopathy. and it's unrelated. If you look in the literature, there's only one factor that's put there as a potential cause, and that is stress. Sometimes people aren't aware they're stressed, but it's stress. And what happens then is you get this small little blister forming right in the fovea, in the middle of the macula. And luckily it tends to pass, and most times it tends to occur once and not repeat. If it does recur, then it may, on a chronic basis, reduce your vision a little.
At night, when my vision has adjusted to the darkness, one eye seems to let in less of the available light than the other. Why would that be?
I'm not sure if this is following laser or not.
No, I'm not sure.
Just generally speaking, the person might have an early cataract. When you start getting an early cataract in bright light, you don't notice it. But the moment the light goes down and your lens is now filtering out even more of the light, then it starts impacting your vision.
What's the doctor's opinion on laser treatment on someone who has diabetes?
It's going to depend completely on how well controlled the diabetes is. I mean, today you can control diabetes so well.
With pumps and so on.
Yes, exactly. That it's not an issue. But if your diabetes is uncontrolled, then I wouldn't recommend it.
Any advances in optic atrophy?
No, we addressed this earlier slightly by the gene therapy. There's promising techniques in the future, but I think it's still a little while to go.
I had laser treatment about 5 years ago. I now feel my eyesight is deteriorating a little, squinting to read, etc. Should I have it done again? I'm 61.
You may have it done again, but the first thing to do is to realize that laser surgery typically is very, very stable. So the fact that it's changed is worth having it checked out again. At 61, you might be getting an early cataract, so it's worth checking that too.
Worth having it checked out. I have a white dot-like thing on the white of my eye beside the pupil. Should I be concerned? That's from Damien in Dunleary.
I don't think so. It sounds like it might be a small little lesion called a penguiculum, which is quite common. But if you're concerned about it and it's something new that you haven't seen before, rather have it checked out. Your local optometrist can also tell you if it's normal or not.